procedures, which I do. I'm uninsured. I was insured and it became so cost prohibitive that I dropped it and I just paid for medical procedures, which is pretty not that expensive if you don't really need anything too much. So I'm wondering, you know, are we going to see medical costs come down as a result of this, do you think?
Well, I think that, so it depends, right? So it depends on how states do things. So one thing that California has done with Covered California is the legislation that created the exchange is what's called an active purchaser model, which means the exchange has the power to negotiate with health plans. In Colorado, it's a passive purchaser exchange, which means any health plan that's licensed can come in and offer coverage and charge whatever premium they want as long as it obeys those premium rating factors. So Covered California did a very aggressive job of getting insurers to come in with bids that are very low, which is why you see the difference between the $1,300 that UCLA pays for my policy versus the $800 that I would pay if I went into the exchange market. So that means that providers are probably getting paid less for that coverage for people who have that coverage and come into their office, and they might be getting paid more by the Health Net policy that UCLA offers. So that could put downward pressure on reimbursement. The problem then becomes, and it's right now that it's a similar problem, where if they're uninsured people or underinsured people in a market and they use lots of healthcare and providers, physicians, hospitals lose money, they charge whoever is willing to pay more money. So often they charge the uninsured more money. So the only people who often pay full price are the uninsured because their insurance company has negotiated on their behalf for those who are uninsured to get a lower price. So that's why when you see a hospital bill, it usually says, you know, charge $2,000, discount $1,200, your price $800, because your insurance company came in and said, we're only paying $800 for this. So if you're a savvy consumer, you can negotiate on your own behalf. Then the risk becomes, do you have unforeseen medical expenses that will occur that are just going to burst the bank, right? And then who's paying the bill if that happens? So I do think that being uninsured for a long period of time, let's say 20 years or so, is kind of like walking a tightrope where you know, there is always this risk of going bankrupt. And given that the way the law is created, if you don't sign up during open enrollment, you can't get coverage. So you wouldn't be able to go sign up anytime you wanted. Then the only option would be Medi-Cal, where you'd have to spend so much of your resources on your healthcare that you hit that level of poverty, and then you qualify for government programs like Medi-Cal. And then I think, you know, there's this fundamental problem in the US where taxpayers don't like this idea that they're spending money on a population that's low income and providing government paid services. So, you know, I think healthcare costs could be forced down by certain innovations. For the most part, I think healthcare spending will go up simply because more people will have insurance. But if the per capita price is kind of leveling out over time and more prevention, more primary care is replacing high-cost emergency room visits, high-cost hospital admissions, then maybe 10 to 15 years from now, we'll end up with a much better, more sustainable healthcare system.
So like there's catastrophic insurance, which is very low cost and only in hospitalization. Is that going to go away? Does it have to be up to a certain standard now?
Yes. So there will be certain plans that are called grandfathered plans that are allowed to continue if they were in existence prior to March 2010. But quite a few insurance companies have said, our grandfathered enrollment is so low that we're just going to drop that plan completely. So there are two ways then that this could work. One is that you sign up for a bronze plan, the lowest cost bronze plan in your network, which for Health Net is between $200 and $300 a month for people, so for somebody the age of 40 for a $5,000 deductible plan, which isn't that expensive. It's probably similar to what a catastrophic plan costs now in the individual market. The other way is that there are going to be specific catastrophic plans only sold by Covered California that are not allowed to be sold anywhere else, that are for people who are under the age of 30 or that can prove financial hardship where any other premium would cost more than 8% of their income. Then you're allowed to sign up in that catastrophic plan. you're still protected by an out-of-pocket maximum of $6,400 a year for an individual. So that's not that bad of a deal if you're paying $200 a month, and even if the worst thing possible happened to you, your only out-of-pocket spending would be $6,400. It's still fairly affordable and manageable.
It's so hard to spend $7,000 when you're not needing it. That's
right.
what's.
But I think the problem is that, you know, health is unpredictable, life is unpredictable, and you know, a 2-day hospitalization will probably cost $10,000. So, you know, if that unfortunately happens to someone, then health insurance all of a sudden retroactively becomes very useful, but you don't have it. You get assigned to a managed care plan. That managed care plan has a network of providers, and to seek care outside of that network of providers, you have to get a pre-authorization from your program. So there are people who have their county of residence in Alpine County, let's say, which is right on the Nevada border, and so they need a pre-authorization, or they need to make sure the managed care plan they signed up for has an arrangement with providers in Nevada to take that insurance. So those issues will stay the same. Where Medi-Cal doesn't provide PPO coverage, they're transitioning all of their fee-for-service Medi-Cal enrollees into HMOs. So you will be guided by the HMO network and would have to stick within that network unless the network approved an outside of network cost. If things are emergency, then they have to approve it. But if things are just, you know, routine and you just want to go see any specialty provider you want and they're not in the network, you'd have to pay out of pocket unless you got pre-approval.
Will Medi-Cal pay for substance abuse, for residential outpatient and intensive outpatient care?
So yes, things are changing though. So right now in Medi-Cal, if you go into LA Care, let's say, they typically carve out all of their services to another mental health plan. So they'll hire Value Options or Universal Behavioral Health, and they'll refer you over. And usually they'll have this private set of contractors that deals with that. One change that occurred in the state budget, this isn't an ACA issue so much as a state benefits issue, is that Medi-Cal managed care is now given responsibility for basically Tier 1 and Tier 2 services, if you consider mental health on the spectrum of Tier 1, 2, and 3, where Tier 1 is, you know, depression screening done by your primary care provider, prescription drugs for basic meds, you know, related to antidepressant or ADHD or what have you, assigned by your primary care provider. Tier 2 is kind of a sticky situation where counseling for depression, things like that, would probably fall under Tier 2, which means it's covered by your managed care plan. So in this case, LA Care would come in and say, we are now responsible for delivering depression care in your primary care medical home and giving you counseling services. But if you need rehabilitative care, we still are using these specialty mental health managed care plans to run it, and it's not our responsibility. So there is a possibility when you're in Medi-Cal that your benefit will get a little bit better to use in-house mental health services through your HMO, but that the really significant issues like rehabilitation care will go outside of that HMO, and, you know, crisis care and things like that will go outside of that HMO, but the HMO is responsible for making sure that that network is available and making sure that that health plan follows through on providing that level of service. So all those things will be provided. It's just how to navigate it becomes difficult when you don't necessarily know where your HMO coverage ends and your specialty mental health coverage starts. And I don't think anybody knows that because they haven't actually released the list of things that are covered by each one. So we're waiting for, you know, the next 2 months to see. One other thing I want to mention though on the Medi-Cal side is that the adult dental benefit is being restored. It was taken away in 2009.
Say dental?
So the adult, so if any of you remember in 2009 we had this thing called the bad economy, and Governor Schwarzenegger and the legislature decided to take out dental care for adults. Dental care for kids stayed. And now it's being restored as of, I believe, May of this year, of 2014. So adults who sign up for Medi-Cal, either under the old program or the new Medi-Cal eligibility rules, would now have dental care again.
How is Obamacare going to affect people with AIDS or HIV?
So that's an interesting question. So, so right now, there are probably 3 different ways in which people with HIV or AIDS get care if they're not covered by their employer. So one is that they qualify for state disability, which means they get Medi-Cal but not Medicare. If you're on SSI payments for 2 years, you end up qualifying for Medicare, and then Medicare might pay your bills. But for people who are not Medi-Cal eligible, not Medicare eligible, they're often on a program called Ryan White, which is a program that is funding HIV/AIDS only, care for HIV/AIDS only. So prescription drugs, well visits related to your HIV/AIDS, you know, cell counts, things like that, CD4 count. But it's not covering regular primary care. So if you want an immunization for something under Ryan White, it can't pay because it's designed by the federal government to be a program for uninsured HIV/AIDS individuals just to cover HIV/AIDS meds and services. So what happens is that we're now growing our Medi-Cal population, right? So if you're on Medi-Cal, Ryan White doesn't factor in because it's only for uninsured people. So now that we're expanding the Medi-Cal population to all these childless adults who were previously ineligible, you're now telling all these, let's say you have a homeless male with HIV/AIDS who isn't eligible for anything now, they go sign up by January 1st, 2014 for Medi-Cal, all of a sudden their Ryan White benefit goes away because they're no longer uninsured, and now you're telling the managed care firm that they're going to be signed up with, LA Care or Health Net, to take care of their HIV/AIDS needs. And the problem becomes if that person was going to AIDS Healthcare Foundation for all their care and had a good relationship with their physician there, they had all these brand name drugs that they had to take as part of their cocktail, they'd figured out what the correct dosage of each one was to keep their HIV under control, and now they're given to Health Net, and Health Net says, yeah, we can dispense all these drugs for you, we'll give you a new primary care doc, but that primary care doc doesn't know how to handle HIV diagnoses, they try to put you on a brand new cocktail of drugs, then there could be a problem with how you respond and your outcome in the future. So people with a clinical condition like that who are moving over need to be very careful about making sure that they pick a managed care plan when they get assigned into Medi-Cal that includes good infectious disease specialists that will cover the brand name drugs they may need that are in their cocktail to manage the illness. And if that's all solved, they should be fine because now on top of the HIV/AIDS services, they're also getting comprehensive healthcare services outside of the HIV/AIDS diagnosis that they were never entitled to before.
One of the questions I have is the premiums based on location. Isn't this a form of profiling and isn't it discriminatory?
So they're really big locations. So there are only 19 rating regions in the state of California. So everybody living outside of Lancaster, basically in LA County, will have the same location. So there's no ability, it's not by zip code like car insurance, it's by these big areas. So if you think about it, we have 58 counties in California, and we're gonna have 19 different rating regions. So there really isn't that much variation, and actually higher income areas have much higher premiums because they spend more on healthcare, and so when the insurance companies come in and price the premium, they say, well, this population has a high spending level, so we're gonna price them higher. So San Francisco's premiums are like $320 for the same plan that's sold for $250 in LA County. So I guess it's discriminating against higher income people.
Okay. How does Obamacare compare to Canada's universal health care? We hear a lot about it's better to get that Canada's doing better than we are, and very rarely does anyone from Canada come to the United States to get procedures.
Well, I'm not sure if that's completely true, but people with lots of money in Canada could come to the US for procedures. So it's quite a bit different. So as you can see from the presentation I just gave, Obamacare is not really government-run healthcare. It's not like you're assigned to a specific plan. Basically what Canada does is a little bit similar from a financing perspective, where they have different provinces, and those provinces deliver and pay for care differently. They have different fee schedules, they have different providers in the network, kind of like we do with states. But for the most part, healthcare is compulsory, and it's paid for completely by the government. And if you want services beyond what the government can provide, you can sign up for an additional insurance plan and get those additional services. So on the detractor side, so what we've heard from Canada is long wait times. I want an MRI, but I can't get one because they view it as clinically unnecessary. So those things probably won't happen here because of the fact that we're using private networks to continue delivering care. And those private insurers are going to make these benefit decisions. It's not going to be due to some sort of government oversight that tells them that you shouldn't do X, Y, or Z for this population, which could be considered a bad thing, right? We know things like spinal fusion are often unnecessary. We know, hysterectomies for the most part are unnecessary now. So in Canada, they've kind of updated the knowledge over time and they use evidence to make coverage decisions. We don't. We rely on physicians to make the choice. And if you have some physician that was trained 30 years ago that is used to taking everyone's tonsils out or used to taking everyone's gallbladders out, they're going to continue to do it because they continue to get paid. So we are still going to be kind of behind other countries in making these evidence-based decisions that hurt financial bottom lines for insurance companies or for physicians. On the positive side, Canada does have better access to care for lower income people, but they do report worse access to care for some members of the population. And I think what will end up happening in the US is that people of lower incomes will probably end up being able to report better access to care. So they'll be less likely to report delays due to cost, less likely to report not being able to fill a prescription drug because they couldn't afford it, and those things. So I think we'll probably level out with Canada in terms of people's ability to actually seek out care. But when you get to things like health outcomes and life expectancy, I think a lot more goes into it than simply having access to insurance. If you think about the social determinants of health and housing, environment, having a safe place to exercise, we're still far behind Canada in those regards, and healthcare services can only do so much. So I'm not sure we'll surpass them in terms of other, measures of health status and mental health or anything like that.
We have a separate healthcare system for illness or injury caused by a patient's work. It is very expensive and is also an ineffective system. Do you envision future efforts to merge the workers' comp system with our broader system under Affordable Care Act?
I highly, highly doubt it. Workers' comp has gone through two major reforms in the past 10 years. And the way it's paid for through compulsory insurance through employers is quite a bit disconnected from our typical healthcare system. And I actually think that the ACA probably represses our need to reform workers' comp simply because part of workers' comp waste and kind of abuse has been the result of people who didn't have insurance making claims under workers' comp for pre-existing injuries or injuries they suffered outside of the workplace. And so we may see some pressure taken away from that type of mechanism if people have actual health insurance that isn't priced on their experience, isn't priced on their risk factors, and people are better able to get care. But I think in California, workers' comp is now viewed as fairly affordable because of the fact that we put so many restrictions on physician payment, physician networks, and the fact that we're kind of moving to an HMO style model for workers' comp.
For a person who's 65 plus and Medi-Cal recipient, SSI, can another person purchase a better plan for them?
Can another person purchase a better? So the Covered California premiums are only for people under 65. So if you're in Medicare, you're not allowed to sign up. So no, not really. And I can't envision anything much more generous than Medicare plus Medi-Cal together, because basically Medi-Cal pays for all of your services that Medicare doesn't cover. The only thing you would be limited on are things like certain specialty services and maybe certain brand name drugs, in which case I think a supplemental Medigap plan is probably better than buying an all new, brand new comprehensive insurance plan through an exchange or private market.
Does the cost of the plan have any relationship to the actual cost?
Yes, if you're talking about the premium prices. So basically what a healthcare insurance company does is they hire an actuary or have an in-house actuary who looks at all of the claims in an area and decides how to price a premium. So they say, we think that everybody in this area spends $700 a month on healthcare based on the data we have and the characteristics of the population. And so we're going to price the premium at $800 because we need to make $50 and we need to pay $50 for commercials and to pay our brokers, etc. So yes, it has to be based on the underlying health risks of the population. The interesting thing that will happen is we are now required to only rate premiums based on age, location, and family size in California in the individual and small group market. So where you used to see variation on diabetes, hypertension, smoking status, etc., it's now all going to be captured in those three factors. So everybody of the same age is going to be charged the same amount of money in a plan, regardless of their underlying diagnoses. And that probably gives an incentive for people who are sick to use lots of healthcare, and people who are relatively healthy to, maybe not use much because they don't need it. And so the healthy are kind of subsidizing the sick in that type of market.
I have an addendum to that question. Does the cost of the plan have a relationship to the quality of the care?
So, not currently. So this is a fight that's going on where Kaiser is saying so Kaiser came in as the highest bidder in a lot of these exchanges, which is funny because usually we're used to Kaiser being the lowest premium plans, and so Kaiser came in and I think they felt like lots of people were going to use lots of services. They were kind of scared about this pent-up demand issue, so they priced their premiums fairly high, and so they ended up being one of the highest cost providers in the network. So now they've been pushing to include quality ratings in the covered California listings, so people can see that Kaiser does 4 or 5 star care and HealthNet does 3-star care. And Kaiser is very good at meeting quality benchmarks. So Kaiser has this electronic medical record, right? And they have very protocol-based care. Like if you go to a Kaiser doc and they diagnose you with pre-diabetes, you get sent home with a 5-page packet that talks all about diabetes because it just printed out of the computer when they entered that diagnosis. And the doctor didn't really have to think about it. They just knew that the decision support system built into the electronic medical record would do it for them. So if the quality measure is what percentage of your diabetic population got a diabetic management plan, 100% of the people with diabetes in Kaiser get one because the computer spits it out as soon as it pops up. People will report they get it. Kaiser can say, yes, this was furnished. And so they look very high quality from the quality metric standpoint because they're all what's called process measures. We typically don't score health plans on outcome measures. We don't ding a health plan because they have high mortality. We don't really know if a health plan caused high mortality because people are with health plans for 1-2 years and then they leave. So we tend to measure their success based on if they follow the standard of care. And Kaiser is very good at following the standard of care. So their quality measures look really good, and other insurers that don't have electronic medical records, don't have a lot of control over their providers, often look bad. So Kaiser, because they're the highest cost plan in a lot of these markets, they're trying to push the exchange to include the quality ratings this year in the listings so they can still get a lot of customers. And so we may see in 2015 that they'll add it, but I don't think it'll happen in 2014. So there's no real link, but the hope is that in the future, patients will look and say, oh, there are 2 plans that are $250 each. I'm going to go with the higher quality one based on, these outcomes reported.
I just wanted to piggyback on the Kaiser thing because Kaiser, Southern California, maybe it was all of Kaiser, I'm not sure, but they got, Kaiser just got, within the last year, they got severely fined by the state for mental health. And they are actually being sued right now for entering or trying to enter into the healthcare exchanges because they're sort of on probation.
Right, so the healthcare exchange is required by law to only allow plans in that are in good standing. And Kaiser is technically in good standing, even though there's this big hubbub about the fact that their mental health network was worse than it should have been and was causing access problems for people with mental illness. So the concern is, if you're now changing the benefit package to include all this mental illness care, and people are going to go sign up for Kaiser, is the exchange doing enough to make sure Kaiser is meeting that demand?
Looking at the Affordable Care Act from a macro basis, we know that some of the red states are not participating in the plan. And a lot of us have family and friends in the red states. How would we advise them to look into the Affordable Care Act?
Sure. So one of the important things when you're talking about more conservative states that have decided not to comply with the law is that states can decide whether to expand Medicaid or not. So for people of very low income, states could decide, like Texas and Florida, we're not going to expand. So people under, right at the poverty level might have a harder time getting coverage and will probably stay uninsured. The exchanges still go into effect. What happens though is the federal government is stepping in and running the exchanges for that state. So the federal government now has a lot more responsibilities than they originally envisioned. They were hoping that every state would develop their own exchange and the federal government would kind of provide oversight. But now the federal government's sitting there negotiating plans, doing eligibility and enrollment, trying to advertise, do open enrollment, all these things. So there are 34 states that are doing a federal exchange and only 17 that are doing their own. So anyone living in those red states would still be able to go into the exchange. The problem though is that the exchange subsidies go from poverty level up to 400% of poverty level. So if you're earning between $12,000 a year and $45,000 a year as a single person, you qualify for exchange subsidies. If you earn less than that, you can only qualify for Medi-Cal. You can't qualify for exchange tax, tax credit subsidies. So actually the lowest income people in those states will not really have access to insurance because of the fact that the threshold stops there. So, but if you live in a state like California, from 0 to 138% of federal poverty level will be the Medi-Cal threshold, and then 139 all the way up to 400 will be the tax subsidy. So it'll shift a little bit from 139 now to 100 to be eligible for credits in the exchange, but anybody under 100% of federal poverty level will probably stay uninsured unless the state expands Medi-Cal. So lots of uninsured people in Texas and Florida and Arkansas. Basically, you can see the map. It's just the South for the most part, and then I think Missouri.
Yes, sir. First thing, I really appreciate you coming out, taking your time to come in to present this information to us. I consider myself fairly educated on this topic, and I think you've filled in a lot of gaps that even I had, so I just want to personally appreciate that. As we know, people respond to incentives. In fact, this whole program relies on people responding to incentives. As such, there are two important dynamics that I think we need to take into consideration. That this program does not exist in a vacuum, and that people will respond to the incentives. The program financially requires that the young, healthy people take up the financial slack in the program. Now, the young being the least employed and the least means, as I'm looking at the charts, it's really in their best interest economically, at least in the short term, to take the penalty versus the insurance program, especially the young thinking they live forever. I work as human resources in a Fortune 500 company. I deal with these guys every day. And I've spoken to them about this and what their plans are. And as far as they're concerned, they'll take the penalty, at least for the short term. That's just one dynamic. The second concern is about physicians. My wife is a physician. She's a general practitioner. And one of our concerns is that there's already a dearth of GP physicians out there as it is, and that with the reduced capitation rates, more and more are seeking to exit the medical field. And as it becomes inundated with 50 million new patients, many of which will probably be very high maintenance patients, are we concerned that that will actually impact and reduce access and reduce quality of care?
Okay. So the first question, so incentives are an interesting one here. So you're correct that we are kind of relying on the young people to come in and be the healthy group in our population. So right now, the penalty is only $95 a year. So if they can buy insurance for less than $5 a month, maybe that's a good deal. There actually are plans out there, if you're earning right around the federal poverty level, or right at 140% of federal poverty level, let's say you're earning $16,000 a year as a part-time worker, your subsidies are so high, if you buy a bronze plan, which is the $5,000 plan, deductible plan, that your premiums are around $5 to $10 a month. So all of a sudden, the penalty and the cost of your premium are pretty equivalent, and then it becomes, do you spend $120 for comprehensive insurance coverage or $95 for nothing? So we'll see if people make a wise economic decision. By 2016, when the penalty goes up to $695, then the premium offered them only needs to get to around $50 a month for it to be a wise economic decision. So I think the game will be, is somebody willing to pay the penalty for inactivity when they're not guaranteed anything? Or are they willing to take a kind of $5,000 deductible catastrophic plan and pay $50 a month for it, because it'll be roughly the equivalent of paying the penalty, depending on their income. So the hope is that people do that. If they don't do it, there are protections in the law to prevent huge issues with adverse selection, one being the open enrollment, but another being what's called risk adjustment. So basically, plans that sell in the exchange, at the end of the year, all these fees are collected from the plans, and plans that take a very sick population, just by luck of the draw and the way their plan is structured, will actually end up getting compensated for losses that they may have felt due to that sick population, and the plans that had a healthier population will be paying for them through these fees. So there's a way of kind of evening out the market. This is exactly what they do in Medicare Advantage, which is an HMO program for Medicare beneficiaries, to make sure that one plan isn't disincentivized from enrolling people over another and kind of cherry picking a healthy population versus a sick population. On the physician side, there are a couple things in the law that try to improve physician supply and payment. So one of them, in 2013 and 14, the Medicaid rates, which are very low in California for reimbursement, are supposed to go up to 100% of the Medicare rate, which is about 2.5 times more than it is now. And that's temporarily paid for by the federal government, but it goes away in 2015. So the concern is, what happens when it goes away? You're able to get all these primary care physicians to start taking Medicaid because you have a new Medi-Cal population coming in, but what happens in 2015 when you get rid of that payment? And that payment raise is getting built into the capitated rates that are going to be paid to Medi-Cal plans, or Medi-Cal providers and plans. So right now, Medi-Cal pays about $450 a month to health plans to take care of the over 65 population, the seniors and persons with disability, and they only pay about $120 a month to plans that take care of kids and adults. And they haven't yet released the rate that they're willing to pay for the childless adult population that's newly eligible and will enroll under the ACA. So we're thinking it'll be around $250 to $300 a month, which is going to the plan. Then the plan would decide, we're going to go contract with this network of providers, and we're going to give the primary care physician $10 a month, we're going to give the specialists $20 a month, and on and on. So there could still be a squeeze on primary care, but the rate is still higher than the current Medi-Cal rates for adults who aren't seniors or persons with disability. And there's actually quite a bit of evidence that the newly eligible population is not as sick as the our current Medi-Cal population. The other thing that has really helped in California, at least, is the fact that we have what's called the low-income health program in 53 of the 58 counties. And this was created in 2010 through what's called a Medicaid waiver, where all the counties were able to show that they were spending money on people who would in the future be eligible for Medi-Cal, and the federal government puts in half of the money. So we have a program now in LA called Healthy Way LA. In San Francisco, we have Healthy San Francisco. In Ventura, we have the ACE program. In Orange County, we have the MSI program. So all of those programs have already assigned these newly Medi-Cal eligible people into patient-centered medical homes. They're already dealing with their pent-up needs related to, demand for care that's been unmet. And they've made quite a bit of progress, and they've enrolled about 600,000 people in these plans, and those people will be automatically converted into Medi-Cal beneficiaries on January 1st. So half of the Medi-Cal population that we expect to enroll in the next couple of years is already getting a lot of the care they need early. And so the hope is that when they do come onto the Medi-Cal rolls, they'll be a lot healthier than they would have been if we hadn't done that expansion. There's also quite a bit of investment in the law to expanding training for primary care physicians. There's supposed to be an additional 800 to 900 slots for internal medicine, pediatrics, and family practice. And there's also this creation of the Healthcare Workforce Commission. Problem, of course, is that the commission was appointed in 2010, 15 people that were supposed to monitor data and give recommendations on how to improve our ability to deliver primary care. But Congress has been holding up their funding, and so they actually haven't been able to meet or make any recommendations or have any staff. So there are elements of the law that were in law that are authorized but haven't actually gotten off the ground because Congress has been holding up funding for it. So that could be a difficulty where there's a responsibility by the federal government to monitor health workforce issues and make sure we have adequate physician supply, but Congress is holding it up. Yes?
I think I kind of detected, in the last question, the notion that the influx of enrollees in the medical, in medical care would cause some type of discouragement of people going into the medical profession, or overburden people who are in the medical profession that create some form of exodus. That sounds like, the propaganda.
Well, I think there is a concern about that. We have 2 medical students from UCLA here who came with me today. I don't know what specialty they're going to choose, but whenever I teach, there are 200 medical students in each class, I think, something like that. And whenever I offer a health policy elective for them, 10 or 12 people sign up. And they're all very dedicated to primary care and kind of mission-driven care. They're likely to go into public health and working in community clinics. But there are 100 of them that have $270,000 of loans to repay, and they're going to go into surgical specialties and other things that are certainly needed. But there's this concern that there's an imbalance between specialists and primary care. And unfortunately, primary care physicians still make probably 4 to 5 times less than specialists. And so I think there's a genuine concern that we don't have enough primary care docs out there to meet need. The problem is that every time we have that concern, we kind of turn out to be wrong because we don't have good measures of what an appropriate primary care workforce is. We always just use ratios. We say for every 1 physician, there should be 3,500 patients without understanding the illnesses, ages, genders, all the needs of that 3,500 person population. So we get things wrong all the time, and I think we need to work toward measuring things like wait times and the ability to see a patient or a physician you're happy with, have a timely appointment, and we unfortunately don't have the data to do that. And Congress and the American public in general tend to be kind of anti-devoting lots of funding to collecting data versus actually taking action. So I don't know that it's propaganda or disingenuous. I just think that there's no clear solution to the problem, and there's so many different things that go into it. One of them being, physicians, even though they complain about workforce shortage, they're still very unable to give up control of their patients to a nurse practitioner or a physician assistant or a nurse to take care of issues that you don't need the training of a doctor to do. And so if physicians were willing to give up the reins to this team of providers, maybe would make a lot more progress in meeting the needs that, and allowing each provider to kind of work to the top of their license and deal with needs as they come along. You don't need a physician to train somebody about diabetes care and management. You could do that with a community health worker that makes a quarter of the amount of money. But physicians often kind of hoard the patients because volume is what drives their salary and drives their reimbursement.
Does anyone else have any other questions?
We have one back here.
Thank you for all the information, very helpful. About citizenship, is citizenship a requirement when you're enrolling, and, you know, does one have to prove citizenship, and also are illegals required to be covered?
So,
And will they be fined if they're citizens or not?
so the undocumented are explicitly excluded from Medi-Cal and from the exchanges. So if you're an illegal immigrant, you cannot sign up for either. You can't take advantage of those federal subsidies. But at the same time, they're not going to be penalized either. So because we're excluding them from the market, then they can't be penalized. If you're citizenship is not a requirement, but legal permanent residence is a requirement. So if you're undocumented, no insurance. If you're documented and you're living here for less than 5 years, then you're allowed into the Covered California exchange, but not into Medi-Cal. Once you've passed the 5-year eligibility threshold, then you're allowed into Medi-Cal, if you earn under 138% of federal poverty level. What California is doing is they're going to keep our existing program, which is called state-funded Medi-Cal for legal permanent residents who've been living here for under 5 years, who are children and parents. So those will stay the same. The state will still pay for their care. Anybody new coming along at that same income level qualifies under the new rules, will go into the exchange, get subsidies, and then their share of the premium will be paid for by Medi-Cal on their behalf. So they still won't have any cost.
But what about in the clinics? There are so many people that are undocumented that use up, you know, a lot of the resources. What would happen with that
Well,
population?
so community health centers, things like that, like safety net providers. So federally qualified health centers get grant money to pay for the uninsured, in essence. So they'll still be able to get care through community clinics. Emergency rooms have a requirement called EMTALA, the Emergency Medical Treatment and Active Labor Act, that requires them to triage and see any patient that comes in, regardless of ability to pay. So you might still see an undocumented population there using services. In addition, in California, we have basically a policy that the county is always the provider of last resort. So LA County hospitals, LA County clinics like Roybal Comprehensive Care Center, they are required to see everybody who lives in LA regardless of their documentation status. So LA County will continue seeing the undocumented population. But the good thing on the LA County side is that they will now have a bunch of paying patients that are now uninsured moving into Medi-Cal or private insurance, where they'll be getting reimbursement from those patients as well. So the hope is that, you know, the losses that LA County has always felt will be replaced by these paying patients. The other important thing to note about the undocumented is that they actually use a lot less care than we often think. There have been several studies showing that people who have private insurance and Medi-Cal are far more likely to use emergency rooms unnecessarily than the undocumented. And, you know, because they're in this, undocumented people are in this non-legal status, often there's fear and stigma related to using those services. Now, if we have immigration reform, that kind of changes the equation, right? So there would be this time period of 8 years where the undocumented would get what's called legal provisional status. They couldn't leave the US for an extended period of time, so they couldn't go to Mexico to get care. And they would then be technically legal to be in the US, but still not be allowed to get into Medi-Cal or get into the exchanges. So there would be a concern that once you take away that fear of being caught and you're giving someone a legal provisional status, but you're also locking them out of getting insurance coverage, what happens to their care and what happens to the needs of that population?